2 years ago, when the state health benefits plan rates went up and it hit 22%, a coalition was formed. And so in that coalition, we had a number of partners, many of them are here today. I'm gonna look down because they don't want to miss one. And so we had CWA join, NJA, FMBA join the Coalition for Affordable Hospitals, AAP, AFT Rutgers, NJA, AFSCME, HPA, New Jersey, PBA, and other organizations and advocacy groups like New Jersey Citizen Action, Working Families Party, and so many more. And the target was really to try to get healthcare under control, to get all of these pricings to be under control. And together we are pushing for legislation, together we're pushing for legislation to really slow down healthcare pricing, to create a benchmark, to hold things accountable, and to, in one way or another, codify OCAP, the Office of Healthcare Affordability here in New Jersey. And so we do want to thank our sponsors as well, Assembly Member, Congressmember-elect, Dr. Conaway, lots of titles, Assemblywoman Reynolds Jackson, who just stepped out, Senator Cali, and Assembly Member Carter also signed on to the bill as well, so thank you for that support. And so now I want to introduce our incredible panel. So we have Deb Cornelaka from NJLM, we have Assemblymember Meyer and Mayor as well. We have Tiffany Stewart from Newark, and we also have Kevin Lyons from NJPBA. And so we're going to go through a few questions. We're going to try to keep it short, but really have this discussion of what does healthcare affordability look like for us. And so I'm going to get started. All good? Yeah. Okay. So Deb, can you explain what are we doing about hospital prices, and what is the goal of the coalition?
Thank you, and good morning, everybody. It's a treat to be here with such an esteemed working group around this issue, and to have members attending the league join us, because I know our nights are late and our mornings seem early. You know, the problem is actually really simple, right? We know, and that's my favorite chart right over there, right? We know that healthcare is accelerating faster than any other cost of living, even with inflation adjusted for it, and that hospitals are uniquely the kind of the exponential growth space. So far more than your other pieces of the healthcare world. And with the consolidation, increasingly more that's falling under hospitals. So it's a growing problem that we can see on a chart like that. But that doesn't tell the whole story, and we have to get, in order to be able to solve something, we have to be able to see it with clarity. We have to be able to see it in detail. We have to be able to measure it. And our challenges, and this is true for NJBA, where I serve as the Director of Government Relations, for us it's management and it's labor, right? This is a management and labor issue. Our coalition is made up of both. We have over 200 employees for whom we provide health care. We represent 190,000 educators across the state who receive health care through state or private plans. And we negotiate with school boards across the state. And we see the same numbers as school boards see of the increasing cost of health care. And we know that that puts pressure on the bottom line of a school budget, just like it does on the bottom line of a municipal or a county budget. And we say, okay, well, we want to solve this, right? Because we know we cannot ask for wages where there isn't money. But when you see how much of the portion of healthcare is eating up the money available, we've got to solve this. So you want to sit down. And here's the example of why it was so welcome for this coalition to form for NJEA. You go to the state and renegotiate our SEHPB plans. And you're sitting with the insurer and you're saying, okay, well, how can we get to the cost? How can we fix this? And they go, well, maybe your member shouldn't go to the doctor so often. Honestly, that's the answer we get, right? That's really not a great answer. I just got to say, it doesn't really sit well with us. And so then we go, well, let's dig into where the costs are. We know the costs are in the hospital, so can we talk about some of those hospital cost drivers? And they go, well, that's proprietary. The pricing that we have as an insurance company with the hospitals is proprietary. And so we can't tell you what it is. And I challenge us in any other sector, in any other industry, in any other consumer space. I mean, when you look at the school budgets, the way we're scrutinized, I can tell you how much pencils cost in the district, right? But healthcare is somehow exempt from having to share, or hospitals from sharing that information with us. So then we sit at a negotiation table, and it's like a three-legged stool where one leg just isn't there, right? You're just not able to have the discussion. So the issue is really pretty foundational, and I want to really emphasize one thing. We want to solve this collaboratively. Our coalition sat down, our first meeting was with the hospital coalition, because our goal is not to cause damage to hospitals. They are essential. We have plenty from a labor space, Plenty of our family and labor working in hospitals doing pivotal and critical healthcare. Our goal is not to cause problems for hospitals. Our goal is to come to the table and go, that chart's unsustainable. That chart is unsustainable. People are paying more than 30% of their income for housing, but they are one healthcare emergency away from losing their home because they're being put in a financial crisis. And we know through the work of United Way of Northern New Jersey and Alice families, the asset limited, income constrained but employed, they are one healthcare emergency away from completely spiraling into financial distress. And medical bankruptcy is the #1 cause of individual or family bankruptcy, I believe, in the nation. So we see the problem is clearly unsustainable. In order to solve it, we've got to sit down and we do what labor does best. We want to sit down and have the conversation. We want to negotiate. But to negotiate, you've got to be able to see what's on the table. I was talking earlier, I can't play blackjack and they tell me, and I really don't, so forgive me if it's a bad analogy. Like, do you want another card or do you want to stay? When I can't look at the cards I have, right? So we're being kept in the dark, and it is putting pressure across the entire system, from the individual to the school board, to the municipality, to the county, and to the state. And then the narrative comes that you all are getting too, your benefits are too luxurious. Well, I think anybody who has needed healthcare would not argue their benefits are too luxurious. They would argue that the system is broken and we need to address it. And we want to sit down at the table and address it. So we need transparency. And if it doesn't come voluntarily, we are happy to help legislate it. We need that compliance because you can't legislate a please. You must legislate a shall and must, right? And then we've got to do what other states have done, which is figure out ways, and we see this empirically, others will talk about it better than me, where you can control the cost of healthcare once you dig into what the root drivers are. The answer cannot be, don't use your healthcare. That is not an answer to the problem, and we cannot have the conversation until the biggest cost driver of the industry sits at the table with transparency and the collaborative spirit that we come to with this to say, let's fix this together. I don't think they like medical that much more than we do, but for us, it's the bottom line of our members. For them, it's a write-off in their tax. So that's really, it's a very simple problem, and the solutions, while the nitty-gritties of them are specific and maybe more complicated, the initial steps into solving it really aren't that complicated. And we're very grateful for the OCAT bill because we want to make sure that we have a structure in place to work on it in the long run. But we know and see empirically we can do better than the status quo in New Jersey, and the status quo in New Jersey is unsustainable.
Absolutely. And when you are bargaining a contract and 40 cents of every dollar has to go into healthcare, we know that healthcare issue is not just prescription drugs, but it is hospital pricings that are driving it up, right? Does anybody else want to add before we move on to the next one? No. Okay. We're moving along. And so, Assembly Member, you have a constituency. Why is it important to your constituents? How does it affect you as mayor? What information is it that you need to be able to continue to advocate for them?
Well, I think we all know that healthcare is something that everybody, you either take care of yourself or you don't. People do that to varying degrees. Yeah. And but all of us at some point or another are probably going to find ourselves going to the doctor, going to the hospital. And I think when we talk about cost transparency, knowing what you're going to be faced with when you go to the hospital is something that benefits everybody. However, if you're talking about a life and death situation, you go to the ER, next thing you know, you could be checked into, admitted to the hospital, and you might not even know that's happening. You could be in a car accident, and this is all happening. But the people that care for you, they might like to have some of that information. And you mentioned, you say that's your favorite chart, but I think in the fact that it's illustrative of the problem that we're having, but it's also kind of depressing.
Yes. It is.
When you see that 100% cost increase since 2008, that is just unsustainable. And where were you going to be 10, 15 years from now? And I remember 20 years ago thinking about medical costs being too high. Mm-hmm. So, but in my district, I was the mayor up until I got sworn into the assembly. But I will mention that when the cost did go up on the state plan, just for our retired employees, it added about $500,000 to those costs. And these are costs that most taxpayers don't see or don't think about. Those workers, they've retired, they've moved on, but we're still paying for them. And then for our the current workforce, I think about $1.5 million. And that was in a township of 250 employees. I can't remember exactly how many retirees we had that qualified for health care, but it's quite a few. But in my district, the 9th Legislative District, we have the highest senior population in the state of New Jersey or any legislative district. So it is an issue that comes up quite a bit where you're talking about Medicare, Medicaid, and all types of every range of programs that people are on, so I don't pretend to be an expert on them. But we want to make sure that they get the best treatment they can at affordable rates. And if the hospitals are not letting us know upfront what those costs might be, and I think I heard earlier for some procedures it could be $5,000 at one hospital versus $20,000 at a different one for the same exact thing. And I don't expect costs to be identical. I mean, we could drive around and look at gas prices, but when you see off by a factor of 4, something's wrong there.
Absolutely. I mean, at 32BJ, we took this fight on in New York, and our Secretary Treasurer would always talk about getting a colonoscopy and how a colonoscopy could cost this much here and then 3 or 4 times over there, and when that's a routine procedure.
$15,000 at New York Presbyterian
For a routine procedure.
for a colonoscopy. It's the average is around $2,000 throughout the state.
And then you... Ay, Dios mío. Was that me?
We're awake now.
Yeah.
That was a test.
But just like you said, no, yes? No, I am off. Do you hear me though? Yeah? Okay. Mine is when we look at hernia repairs, right? If you go to Morristown Medical, it will cost you $8,000. Oh, there we go, $8,000. But if you went to RWJ, it's $21,000. So it's 3 times that price. And if, like you said, if it's an emergency and you go to the doctors, the hospital, it's an emergency, you're not asking, you don't know the bill, and then you get it at home, and then what do you do then? It's not like you could go back and say, take it out.
Exactly. And like when your life is on the line, or maybe something less severe, you really need to get treated now.
Absolutely.
And the best thing is prevention, but sometimes we don't have control over everything that happens to us. And the taxpayers also demand quite a bit from elected officials in terms of transparency, in terms of where our money's going. So.
Absolutely. And the solution isn't don't go.
Yeah.
The hospitals can have a full reign, but we're telling the workers, the constituents, well, maybe don't go this week. Go next week when your paycheck's a little higher. Not the answer. So Kevin, you're always talking about the state health benefits plan and information that you need. And as we are trying to push legislation, what do you see are the biggest barriers in opposition to introducing or passing hospital pricing reforms at the state level? What challenges do you experience when trying to build consensus around this policy issue?
My bosses are going to get phone calls after I talk about this, so I don't care. When I first got on the design committee back in 2012, I asked them some questions, some direct questions. And for those of you that don't know, when Chapter 78 passed, we were given 6 seats of labor, 6 of management to change any plan designs. You need 7 votes. So I started asking, how much does this service cost? How much does that service cost? The representative from Horizon said, we can't tell you, it's proprietary. So we're paying for that with tax dollars. And that is held true to this day, right? That for us to get data is absolutely, they throw every single roadblock they can up for us to get data. We just don't get it, right? So how can we make legitimate plan decisions if we don't know what things cost, right? Because the problem is that there's somewhat of an incestuous relationship in the state of New Jersey. The hospital association, the insurers, and the division don't really work against each other at all in the public interest. Hospitals are nonprofits because they're supposed to serve the public. They're not there for profit. But now venture capital is getting into hospitals, so we just have these barriers put up in front of us to try and make these decisions, because the only way to fix this is to be disruptive, right? We have to be disruptive to the system. Nobody wants to be disruptive, all right? Nobody's got the interest in it. I think some of the problem is misaligned incentives, medical loss ratio, where the insurers can only make between 80 and 85%. So what's the only way for the hospitals to make more money, or the insurers to make more money, is to pay more for the services, then their 20% gets bigger, right? So it's a misaligned incentive. That wasn't the intention of the Affordable Care Act, but it's certainly an unintended consequence. I think the barriers that I see is every time we try and change something, when we met with the hospital associations, as Deb referenced, I said, listen, you're going to have to do something. Otherwise, we're going to have to look at a reference-based price model where we would set the rates. The chief lobbyist for the hospital association said this to me in no uncertain terms: we'll balance bill your members then. So I get a threat back when I'm trying to negotiate, right? That's what we're up against. They don't like anybody getting in their pockets. And one of the things we've just recently done, and we're very happy about, is we started a Centers of Excellence program that should be in effect in about April, because all the marketing for hospitals, the Mets had, I think it was New York Presbyterian patches on their uniforms during the playoffs. Mm-hmm. You know, where's that money coming from? It's coming from the insurance. It's coming from our insurance plans, which is our money. And the problem is the Consolidated Appropriations Act of 2021 put hospital pricing transparency out there. It's law. And 36% of the hospitals in this country have decided to comply. Awful nice of them, right? It's 36 still, right? So it's just every single barrier that's thrown up, all we get is attacked when we try and do something, and not getting the data. Who here has bought a car in the past 5 years? Did you go in to take the car and then say, send me the bill? That's what you're doing at a hospital, because your insurance, especially for us, a lot of our members are paying 35% of the cost of the premium, which for Direct 10 is going to be $17,044 next year. That's the member's share. That's the member's share of the insurance. So we have to do something. The rates have gone up 59% compounded in the past 3 years. If we don't do something about that, and like Anna Maria said, that's money that can't go in their wages, that they can't pay for their kids' college, and they can't do, and it's coming out. And we're, you know, I always say, us as public employees, we get a double whammy, because not only are we getting those huge increases, we're paying property taxes that subsidize the other 2/3 of the cost. So I think I'm going back to that disruption word, and if we. The old Albert Einstein quote, right? I actually heard, I was going to use it today, and I heard somebody on the news say it this morning. We keep doing the same thing over and over again, expecting different results. That's the definition of insanity. And we're insane right now. So I think we have to keep drilling, and I think these price disparities that have come out with the little bit of data we have been able to get together, you know, it's mind-blowing when you see the charts, and I don't see what the issue is. We just want to know what we pay. So maybe, but the hospitals don't want to do that because we might steer people to other hospitals, right? So they're going to fight back on that. And they've got, when I had the opportunity to do a fly-in to lobby federal pricing transparency back in January, and a congressman from New Jersey told me, the Hospital Association throws a lot of money around up here. It's going to be tough for you. That's so discouraging, you know, because this is what other public interest is. 100 million people in this country are in medical debt right now. 100 million people, because they can't afford the services that they should be getting. That's almost 1 out of 3. So why is this okay? Why is this system that nobody else has in the world still, why do we allow them to drive the boat? I think that's what we have to get back to.
Absolutely.
And if you see that chart over there, that's right out of the Aon report. Don't mind if I get up.
I was going to ask you to explain the charts.
So this is hospital utilization last year. That red line going down, it was down almost 4%. Here's the cost of services. It's up 10% in a year. In a year. Why is that okay? Why don't they have a benchmark? If the car insurer wants to raise your car insurance rates, they have to go through Dobie, right? They have to get approval through Dobie. Why are we not doing that in the medical industry? And that's what the important part, one of the important parts of our bill, is that it will create benchmarks, and the hospitals are going to have to justify if they go over those benchmarks. So that's the short soapbox speech. So.
Absolutely. And then compliance and enforcement.
Right.
Right? You can legislate a police. Absolutely.
Yeah, and I could just add to that, it's why it's critical that we have the two parts. The transparency is foundational and a first step, but that benchmark piece is critical, right? Because it's when, you know, if pricing is transparent and I have choices of where to go because I'm planning a scheduled procedure, I can look around, or my union can recommend go here versus there. In an emergency, you don't have that, you know, luxury or time, but that's why we need the benchmarks, right? And that's the OCAT office that was set by executive order by Governor Murphy can just go away at the next term, right? If the next governor doesn't decide to continue it and invest in it. And it's also just under-resourced for the monumental amount of work that it has to do. And so that is, the second part of what we really want to see is that institutionalized in a way that it can't go away, and that the same kind of expectations that are put on car insurance are put on health insurance and hospital rates, right? And it has to be baked into our system. It can't be like let's do it this year and then just see what going forward, how it works out. I think we have definitely enough empirical evidence of what the trends are absent any guardrails and restraints. So we need to really make sure that we build this into our system moving forward. And I will just acknowledge, right, again, because we come to this in a collaborative spirit, we want to solve this problem. We don't think it's sustainable for hospitals to do this either. But we do understand, I represent educators, right? They know when there's a child running around in the recess yard and it's like called time to come in, it's hard to bring them back and kind of get them to sit still, right? Well, if hospitals have been out there doing this for so long and nobody's said, you have to do otherwise, it's not easy to say to them, well, now you got to do it differently. And that is why I think it's so important that you are here today and that we build a coalition bigger, because this isn't about tearing them down. It's about getting them to the table to be good partners. And I think once we can make that through some disruption a shift, we can have a whole different dialogue, right? A year from now, we could be talking about this in a completely different way that is actually moving us towards solutions. But we've got to get them there.
Absolutely. And so moving us along, so what now? What is this all about? How do we proceed? And so for Tiffany, if we can't pass healthcare pricing reform, what is at stake? What do you see as the impact of the affordability crisis, and what can we do about it?
So I think that it's twofold. You have the impact on municipalities in general, because you have a set budget that you have to work within, and that set budget is dependent upon the income that municipality is bringing in, but then you also have the impact to the employees. So essentially what that means is a lot of hard decisions have to be made. So for example, for Newark, we were faced with the hard decision of whether or not to stay in the state health benefits plan or to come out self-insured. And we had to make that decision not just based on the 22% increase that we were facing that year, but with no data on what we could potentially be paying. Now we're projecting at this time what we think might be those costs, but we didn't actually have any data to substantiate that. So you're faced with a lot of hard decisions. And in addition to that, the employees are faced with decisions of whether or not to go and get care. You have over 80% of people who defer care or forego it altogether because they're afraid of the medical bills that they may receive. So I think in terms of what we can do while the coalition is doing what it needs to do in terms of hospital reform and then upstanding the OCAT as well, I think one of the things that municipalities and employees can do is look at whether or not, going self-insured and having access to that data is something that would be beneficial. Now, that being said, it's not an option for everybody, which is why there's still a number of municipalities in the state health benefits plan, because like you said, they have those loss ratios that they have to look at as well. So if your loss ratio is too high, you can't go self-insured. Nobody's going to insure you because the insurance company is not going to make money. So that's the unfortunate part. So you have to be in a certain situation in order for that to even be a possibility for you. And then if that is a possibility for you, you have to come up with creative ways to manage those costs. So now we are self-insured. So we have access to that claims data. We know where our spends are. It's hospitals and out of network, but mainly hospitals. And so having that data again, there's no way for you to negotiate with the hospital and say, okay, these rates are too high. We can go over to Overlook and pay $4,000 for a procedure that you're charging our members, $20,000 for. We don't have that ability. So then what has to happen? Instead, you have to look at creative ways to try to offset that. Not only offset it for the benefit of the municipal budget, because it's finite and you have a certain number of dollars to work with, especially if you don't want to see property taxes go, through the roof and things like that. But also for the employee, because if as self-insured, what we pay for the overall medical budget is going to determine how much they're going to pay towards their premiums. And every time you have, every few years when you're renegotiating collective bargaining agreements, all of that, additional money that they may be received is being eaten up by the additional premiums that they're paying towards their health care. So specifically in Newark, some of the things that we've done is look at the healthcare budget as a whole, meaning if I can save them money on their dental premiums, if I can save them money on prescription costs, we've been able to nearly cut our prescription costs in half. If I can save them money on voluntary products, for example, long-term disability, short-term disability, accident insurance, things like that, things that people might pay a few dollars for on every paycheck, but means a difference to them because if they happen to be diagnosed with cancer, or they happen to have a short-term disability where they have to be out of work, they have some protection to be able to continue to pay their rent or their mortgage, to buy groceries for their family, to take their kids to the doctor if their kids are sick. So you have to be creative and look at it universally, so that it's both beneficial for the municipality and also for the employee. But that's one part of it. The other part of it is making sure that we're supporting this new bill, making sure that we're advocating for it, making sure that we are letting legislators know the importance of having access to the data, first of all, so that we can figure out where the discrepancies are and make benchmarks that are reasonable. Like we talked about, it's not about, the coalition just trying to come in and disrupt everything. It's about partnership, and it's about making sure that, okay, we know that the cost, hospitals routinely accept Medicare payments as payment in full for particular procedures, right? So if they routinely accept Medicare payments, which we consider to be about 100% of the cost, like for the hospital, why in New Jersey are we paying nearly 700 times that? It doesn't make sense. So it's not about, the hospital being able to sustain itself. It's like other panelists have said, it's become a business essentially. And there has to be some curtailing of that, because there's no reason that New Jersey, for example, should be paying 670% times the Medicare rate for routine procedures, which is what's happening. So I think it's those two things together, looking at what you can for the right now,
Right.
and then working on what we can for the future so that we can stabilize costs and have some identifiable benchmarks that people, can actually live on, in terms of, like the employees being able to bring home money to their families and support their families while still getting the care that they need.
Daily struggle.
Can I say,
Absolutely.
Kevin, you probably have better data stored in your head on this, but the other thing that we've seen in this is there's not a relationship between how much they're charging and outcomes, and there's not a relationship between how much they're charging and wages and salaries. Is that?
Yes, yeah, we have another slide, but I don't have it with us. But yeah, no, we've got illustrations of that where Medicare ratings don't equate to what they're charging. Because Medicare does a star rating for the different facilities. and they don't equate exactly to what the hospitals charge. And I'm glad you said that, because I left that out about the multiples of Medicare that some of the hospitals in New Jersey are receiving is insane. It's nauseating when you look at spreadsheets. But it doesn't mean, as to your point, it doesn't mean that they do a better job, right? So and then readmissions, and that's what the Centers of Excellence should help with, because they're going to be quality based. I think a good point with that is that we are not good consumers with healthcare, generally. We don't shop around. We don't look at leapfrog ratings. We don't look at quality ratings for different things. We go because our doctor said is affiliated with this hospital, so we go to that hospital to go get, I'll just keep using colonoscopy. You know, we don't shop for it. You know, but if we have the data, we as the trustees of the plans can direct people to go that way. My members don't like hearing me say this. I know my brothers and sisters in labor are not going to like this as much as I do, but we're not good at choice. We're not. I'm not. You know, and I think we have to get people who are good at choice to direct us to the right, to the more efficient places, you know, for our healthcare needs. You know, primary care, you know, like Integrity Health does is the centers. If we center it around primary care more, you know, that's going to save us a lot of money. So there's lots of things we can do, but once again, go back to that word disruptive, right? We have to be disruptive in the current healthcare industry because they love the status quo right now.
Status quo works for them until it doesn't, because it will break the system. I mean, that's the point, is that the system will break eventually, and I don't know what they think is going to happen then, but it's going to be a crisis of really untold magnitude.
And the problem with the state right now is that the state has ceded all its responsibilities, its fiduciary responsibilities and everything, which they're not fiduciary responsibilities, but to the vendors, right? So it's the fox guarding the hen house right now. And it's not that the people in the division aren't trying to do the right thing. They don't have the tools. We don't have medical directors and pharmacists and on staff like we should on the state side. I'm just talking about the state side right now. We should have all that looking out for the state's interest. And there's a slew of breach of fiduciary cases, and they're going to come against the town leader soon, because if you don't know what you're paying, this is if you follow these circles, there's lawsuits every day that come out, and Wells Fargo, J&J, Minnesota, and these cases are going to come back, because if you're hiring an insurer as a town leader, you're responsible to know what the costs are. You have that responsibility. So,
I was just going to say, I think it's one of the key takeaways from this panel is that we all make data-driven decisions, and when it comes to when you're hiring employees, if you're looking at police officers, if you're looking at hiring new teachers, there's costs associated with all that. And I know we would always do an analysis of if you had people leaving, what was that person being paid by what the newer people, typically coming in at lower rates, are going to cost. Talk about pension contributions, talk about everything down the list. But when it came to healthcare, oftentimes you didn't know. I'm just saying with the costs that we had available to us, if it's a younger single person, they're going to cost less than someone with a family. But the point is we want to have that data, and we should also be able to get similar data from hospitals for what they're charging.
Absolutely. And if I could just add too, the issue of going in and out of the state plans, we have that with school districts as well. While it should be a right and a choice, it should not be something that is forced upon you because you can't afford to stay in a plan because you're not given the data and the tools to be able to. And we see so many school districts who go out for a year or two, and then the same thing happens outside, and then they come back in, and then they go out. That instability, that's a cost of resources, right? The business administrators and the processing that it takes to do new plans. I mean, that is all resource lost because they're trying to shop for this, where the state should be able to assure a certain kind of better price, and efficiency in the plan that should be applicable across the entire landscape. But the fact that we see so many municipalities and districts doing that, again, is a sign of the trouble. And I'm never going to argue that you shouldn't have that right and option, but it shouldn't be one that you feel like you have to take because you're being blindsided.
And 2% of the rate increase this year on the local side was just for adverse selection for the people, the healthy lives leaving the plan.
Right.
Thank you, Nork.
No, absolutely. So a lot of information, and I think everything that I'm hearing, right, we have legislation at the federal level to hold hospitals accountable. How much? What percentage are hospitals actually complying? 36%. You said 100,000 million? No.
100 million people in this
100 million
country are in
people.
medical debt right now.
Are in medical debt. And it's because they're going to hospitals and they don't know what it's going to cost them, right? And I think, Tiffany, a lot of what you said, right, is going back to educate our members, going back to educate constituents, to let them know what it is. And you're right, we're not people of choice, but I think it's because we just haven't had the opportunity to do that.
Right.
We haven't had the actual options to
We can't
say,
make educated decisions right now.
no, because the information is always proprietary. And I think this legislation that we're pushing, just like Deb had said, we can't legislate it, please. And so with the legislation that we are pushing, there are benchmarks with it, there is compliancy with it, there's enforcement with it. And I'm just gonna name the bill so that people have it in their minds, but we are asking to continue to support Bill 84713 on the Assembly side, on the Senate side, 3571. And this is to continue to make sure that we hold our hospitals accountable. We are gonna now open it up for questions, if folks have any more questions for us, or any last remarks that we wanna say. And there are mics all around the room.
You know, one of the things, I don't see anybody, one of the things that's frustrating to me as a retired public employee is that my pension is posted on Data Universe, right? I'm not active anymore, but my pension number is on Data Universe. Everything we do, especially police licensing, is new. Our entire personal lives are scrutinized now as police officers. We can't know what hospitals charge. That's tax dollars, right? It's tax dollars in this. And Allie pointed out to me before that those numbers, that utilization number, that came out in the OCAT report. That's essentially across all health insurance plans in New Jersey, even private ones. So there's something wrong there. There's something wrong here. You know, there's another slide here that shows how much year over year health insurance has gone up and what the average contribution is versus the total cost. For the first year, it's $25,000 nationally for health care. The state health benefits plan is over 50. So, you know, there's no reason that we can't, we just need to know what we're paying for services. And I think that if transparency is good,
Yeah.
sunlight's the best disinfectant, and that's, you know, that's what we're looking for.
Absolutely. And when you said that rate, we had the 32BJ Health Funds had a conference in New York. You joined us. Thank you for joining us. And what one of the speakers said there was that for each person to be able to have health care, it would be like giving every single person a new car.
Right.
That $24,000.
Yes.
That
Yes.
is exactly
Yes.
what healthcare costs.
Yep.
And the number one driver is hospital pricing if we don't rein it in. And I think, Deb, as you said it, we can't let them play in the play yard and not be able to bring them in. And it's gonna take some kicking and screaming, but the reality is we all have to be partners in this. And hospitals have to be partners in this. The unions are coming together, advocacy groups are coming together because it affects us all. And I also just want to acknowledge Congresswoman Mikey Sherrill has stepped in, so thank you so much for joining us. Thank you so much for joining us. We have other elected officials. We have people from our Hoboken, Mayor Ravi Bala, the council members are here, and so thank you so much, everyone, for joining us. We also welcome folks to join the coalition. So we have our Affordable New Jersey Coalition for Affordable Hospitals. Ali is here, and if you want to join or if you want to find out more about the legislation, more about the coalition, please come and join us. And I think after here, we'll still mingle if folks have any more questions.
There might be one question. Can I?
Oh, go for it.
Yeah.
Oh, I didn't see
One
what the light.
question I want to ask.
I'm sorry, I came in late. I had another meeting. I was wondering if there is a definitive obstacle, somebody that we can point to that's in the way of hospital transparency. How this coalition, which I'm proud of the work that you've all been able to do. What's the next step? Who is our obstacle that we need to overcome to get this done? Was that stated while I wasn't here? I'm sorry.
Anyone want to chime in?
It's the hospital association.
Hospital Association.
Yeah, I mean, it's
Horizon.
hospitals leveraging their power. We will name the hospital association. They are made up of the hospitals, but
Right.
it's really, that's the space. And they will give us I'm going to be slightly uncharitable, excuses every time we have a conversation, right? You wouldn't understand the data if we released it. Releasing the data won't solve the problem. Well, we never said it did. It's just the first step to getting towards the solution, right? There's too much data to release.
Well, that's what Hackensack, go on Hackensack Meridian's website, look at their data, there's 500,000 lines of data. They threw the whole kitchen sink at it so you can't dig out what you need.
Yeah. But
The other part of that question is the municipalities, the taxpayers basically, are they actively joining this coalition? Are they getting involved with the coalition so we can have all New Jerseyans trying to come together on this one issue to take away some of the power, the influence of the Hospital Association?
Yeah, well, I think it's important that, like we said, that municipalities join the coalition. I mean, it's an issue of the unions, municipalities, constituents, because this affects everyone. And so the more collaboration that we have across the table, I think the better the outcomes will be in terms of being able to achieve the goal.
Yeah. And if I could make a polite plug, anybody who is a member of the League of Municipalities, there's a board that can make the decision to join us. We've had some really productive discussions. We would encourage and be honored if you would go back and have that discussion if you're a member of the League and say, we think this is a valuable place to lend our organizational support. This is a labor and management issue.
Yes,
This
it
is,
is.
and we are united on this. And we all suffer the same tension at the bargaining table until we solve this. And we don't want to fight with each other over this. And if I could just add very quickly, there's a domino effect to this, right? Of some of what Kevin talking about. I don't know, in education, there's huge staff shortages. In municipalities, I'm hearing increasingly, it's hard to fill posts. In state government, it can be hard to fill posts. One of the reasons is we know we're not going to be the best paid, right? Teachers don't earn the salaries that a professional with same levels of degrees do. We've offered good benefits. And the more we chip away and erode those benefits, the harder it becomes to be competitive. And those shortages are a direct result of problems like this. If you go into the private sector, you can get a much higher salary, even if your benefits aren't as great, but very often their benefits are better. So we've got to address this just to maintain basic levels of staffing. Our crisis in classroom is really problematic. One of the ways that I favor to see hospitals brought a little bit is to say that if you're not complying, like instead of the please, you shall and you must, if you're not complying, you cannot go after medical debt. You cannot sue the consumer, right? And that's a level of consumer protection and a strong incentive for them to get on board and do the right thing. Yeah. Those are pieces that we've talked about seeing in legislation in order to both protect consumers and, sometimes you have to get a kid in from recess with a firm hand.
I want to thank you all for your resolve in tackling this huge problem that the members of New Jersey State PBA are really confronting, I guess. Thank you very much.
Thank you so much.
Mayor.
So I have I'm a local municipal official and have the benefit in that capacity to be on a hospital board, the CarePoint hospital system in Bayonne, Jersey City, and Hoboken. My job is obviously to represent the interests of the hospital, but also I'm a community member who also is on the board to represent the interests of the residents of the city where I live. So my question for you is are there any models in terms of hospitals within New Jersey where there have been discussions and engagement and progress that we can point to as, this hospital system here or that one there is one that is a best practice or is doing good work, or is this a holistic challenge statewide?
The data that we've been able to come up with, there are some decent actors in New Jersey. I don't want to say it's every single hospital. I met with Holy Name, and their numbers are pretty good in a lot of places as far as the multiples of Medicare, what they charge. The issue becomes, and then you have UMDNJ, they charge like, what is it, Dudley, 120% of Medicare? Is general what they charge across the board? That's what they get paid. Right. So there are good actors, or better actors, I should say, But by and large, you know, you go to them and you hear the break even's about 120% of Medicare. That's what a break even should be for a hospital to make. They'll argue it's 200 and some, right? But that's because, well, I don't want to get in bit more trouble. So, you know, but there are models out there. Some states have gone to what's called reference-based pricing, you know, where the state sets what they're going to pay. And that's the nuclear option, right? You say, all right, we're going to pay 175% of Medicare for all services. I don't think that's completely the answer, personally. I think there's some guardrails we could put in, lack of a better term, but because some CMS payments are not enough, some are too much, right? So you don't want to just go a flat number. So there's a lot of models across the country. Oregon just went to that. Montana was in it, but came back out. They were 234% of Medicare. I think they're the only ones right now. Or Montana's out. They just went back to the old model, and their healthcare prices went through the roof again.
Thank you.
We have seen other states that have done the work that we're proposing to do here and see the rate of decrease, right? Is that the right way of putting it? And cost control. So we've seen empirically that what we're proposing here has worked in other states. But I will say too that while there might be a couple of hospitals that are better, it's also very inconsistent, right? So like a knee replacement at one hospital may be way out of whack, but it might be a colonoscopy at another one which is way out of whack. So where one is more expensive, they're not necessarily more expensive across the board. So we can't read into the data. And we don't have complete data. It seems to be, it's irrational from the way I see it. And I don't see enough to be able to say that with certainty, but it doesn't make sense. You know, if you saw one hospital and you were just like, okay, they're the Mercedes-Benz, they're the, you know, the Rolls-Royce of hospital costs, and somebody else is the Toyota, but it's not that way. Depends on procedures but again, we have incomplete data to really judge that.
Okay. So, please join us at the mics.
Hi. Really good discussion, Maura, with Citizen Action. Happy to be a part of this.
Absolutely.
I was using my outside voice.
It helps with the recording.
Maura with Citizen Action, proud to be a part of this effort, which is much, much needed, and everyone in the room, no matter what your role is, can and should be a part of this coalition. I just want to say, in the end, the effort on OCAT that Deb and all of you talked about, the state has to get over itself that we cannot put price caps on services. That has been the ultimate battle. We now have benchmarks, but there's no enforcement. It's just a suggestion. And what this effort is about is making sure if you don't meet the benchmark, there's a penalty to that. And we got to stop siloing all of the issues, right? We talk about property tax relief, and we've got this huge program that's going to cost us $2 billion called Stay NJ. Well, the reason the property taxes are so high is look at all the numbers you heard today. It's got a lot to do with our health care. And so if we control the cost up front, we won't have to have all of these other fixes at the back end. So I would encourage you all, League of Municipalities, businesses, individual taxpayers. We have an NJ for Healthcare Consumer Health Coalition. All of us need to be in this, and the next governor, whoever that is, needs to be with us on this. So thank you for bringing this out. Thank you for continuing to work on this, because together I think we can really get somewhere.
Absolutely.
Thank you.
Thank you, Maura. And you did mention penalties, and I don't want to scare or alarm people, right? We don't want to hurt the hospitals. Hospitals are our friends. In the legislation, compliance has different steps, right? It would mean if the hospital is not complying, that there would be a performance plan that they would go on. If that's not working out, we would bring them in and they would have to, see people to their faces and be able to say, why are they not following the plan? And then if that's still not working, then do a penalty. So there are steps in the legislation.
We're big believers in due process up here.
Absolutely.
Allie, with Massachusetts, how did that affect them? Massachusetts put a benchmark in, and how much money did they save?
Yeah, well, Massachusetts, in the 5 years after they instituted their benchmark program, they would have saved their cost growth went down below the national average, and compared to if it had stayed at the national average or above, they saved $7 billion over the course of, that's the entire commercial market, employees and employers, over the course of 5 years.
That's a pension payment in New Jersey.
Absolutely. So I know folks are running and it's 11 o'clock. So last two things, right? Join the bill. If you want to join, if you want to find out more about the bill, just meet us there and join the coalition. This is a partnership of so many of us, of organizations, of unions, of municipalities. So come and join the fight, right? It's a crisis. We have the power to rein it in and hold it under control. Thank you all.
Thank you for being here.